Hello everyone. Today we will be covering history taking of chronic suppurative otitis media. So we will be taking all the symptoms related to CSOM in detail. So let's go. We will be talking about chronic suppurative otitis media. So in present days the terminology has changed and it is also called chronic otitis media. In simply it is called chronic otitis media. So the symptoms related to chronic otitis media will be the following. So first, chief complaint. Among the chief complaints, the first and foremost symptom will be patient will be coming to you with complaints of ear discharge. Next it will be they can come with complaints of hearing loss. Then third, they can come with chief complaints of pain in the ear, also called earache. Okay, and next they will be complaining about tinnitus, which is also called ringing sensation or abnormal sound in the ear. Abnormal sound in ear, either one or both. Next it can be vertigo or giddiness, right, which is also called spinning sensation of self or surroundings. So we will be taking each of these symptoms in detail. First of all, we will talk about ear discharge. So if we talk about ear discharge in detail, first and foremost we will ask about ear discharge, the amount of discharge. How much is the amount of discharge? Okay, it can be scanty, which is less. Okay, it can be profuse or also called copious. So why will it be copious or profuse? Why will it be? Because of the epithelium lining of the middle ear cleft. Middle ear cleft is lined by columnar epithelium. So what if it is columnar epithelium? Why will it be profuse? Because it will contain goblet cells. Goblet cells will be there, and these goblet cells will do what? They will secrete mucus. So it will secrete in irritation when the perforation is there, and when the middle ear cleft is irritated with the surrounding or the environment, dust or anything or air, it will get irritated and then goblet cells will secrete mucus. So because of this, that will be profuse discharge. Okay, so why will it be scanty? This will be an unsafe type. In unsafe type, it will be mostly epithelium. Okay, it will not be columnar epithelium, it will be keratinous epithelium like our skin. So it will not be having any goblet cells, so it will be scanty or less. Next, if we talk about the characteristics, if we talk about characteristics of the ear discharge, second we will ask about the duration. It can be more than, or it can be less than 3 months, or it can be more than 3 months. Different books tells differently. If it is less than 3 months, they will say it is acute, and if it is more than 3 months, it will be chronic, and if it is in between, it will be subacute. Okay, so next will be about characteristic or type of discharge. Type of discharge, it will be it can be watery, it can be, this is not solely about the CSOM, any discharge coming from ear. This will be a watery, it will be serous, it can be mucoid, it can be mucopurulent, it can be purulent. Okay, so if it is watery, so different types of discharge will tell about different diagnosis. If it is watery, it will be mostly because of CSF otorrhea, CSF leaking from the cranial cavity. It will be mostly in traumatic cases. Okay, head trauma. Next, it will be serous. When will it be serous? Serous will be in otitis externa. Why? Because whenever in any part of your body where skin is there, if any trauma occurs or injury occurs, what will happen when it is healing? There will be some discharge with the scab. You will be seeing discharge that will be not mucoid also, that will not be thick also, and it will not be exactly like watery also. It will be thin, but it can be colored little reddish yellowish. So this will be in otitis externa. Otitis externa because external ear, EAC, external auditory canal, it is lined by same as skin epithelium, squamous epithelium. So this will be same. Mucoid. When will this be mucoid? If it is mucoid in nature, what will you think of? Otitis media. Why? Because I've already told you otitis media. There will be no otitis media. Middle ear is lined with columnar epithelium. Goblet cells will be there. It will secrete mucus, and because of that, discharge will be mucoid. Okay, mucoid. Next will be mucopurulent. When will it be mucopurulent? When the discharge is mucoid, that means it is coming out from the middle ear cavity, middle ear cleft. And if it is again added by suppurative, also called suppurated infection with any bacteria entering into the middle ear cavity through the perforation or through the eustachian tube, which is present in eustachian tube opening is present in nasopharynx. If you have any URTI, upper respiratory tract infection, then bacteria may climb up from the eustachian tube and cause bacterial infection, which will cause mucopurulent discharge, superadded infection. When it remains untreated for long time, this mucopurulent will turn into purulent, long standing. Okay. Next about the discharge, we will ask about if it is intermittent or it is continuous. Nature of discharge, whether it is intermittent or it is continuous. Okay, when will it be continuous? Continuous will be even if you take medication also, it will not stop, because it is because of when it is continuous, but it will not be profuse, it will be scanty, but it will be continuous. This will be in unsafe type. Intermittent will be in the safe type. And in this intermittent, what will happen is it will be relieved with medication. It will be stopped, and then it will aggravate in URTI. Okay, when in unsafe type, it will remain constant. It will not be decreased with medication. It will not be aggravated with upper respiratory tract infection also. Next, we will be asking about odor or smell. of the discharge. In this, what will happen? What we will ask is whether the discharge is foul smelling or not. Foul smelling or not foul smelling. Okay, foul smelling, when we will see, it will be either in the suppurative infection. Previously we have seen in mucopurulent discharge, it may occur there also, but mostly it will be in unsafe type. Why? Because there will be erosion of bone, and this will be mixed with the discharge. That is why foul smelling will be there. Not foul smelling, and it will be in the safe type. It is also called mucosal type of disease. Next we will be asking about whether it is blood tinged or not. Blood tinged discharge. Where we will see blood tinged discharge, it will be again in unsafe type. Why? Because previously I have told there will be erosion of bone. So inside the bone there will be small capillaries which will contain blood. So erosion of bone will finally erode these small capillaries also. There will be bloody discharge or blood tinged discharge. Okay, and this will not be there in safe type. Not blood tinged, as it will not erode the bone. Okay, so these are the main expansion of the symptoms. Again we will see once again. Here discharge, first we'll ask about the amount. It will be scanty or profuse. Scanty will be seen in the unsafe type, and profuse will be seen in columnar or mucosal type, that is safe type. Duration, if it is less than 3 weeks, it is called acute. If it is from 3 weeks to 3 months, it is called subacute, and if it is more than 3 months, it is chronic. More than 3 weeks, less than 3 months, it is subacute. And next type of discharge, whether it is watery, it will be there in CSF otorrhea because of the head trauma. Serious discharge will be there because of there is infection in the otitis, infection in the EAC, external auditory canal, otitis externa. And mucotype will be there in otitis media. Why? Because there will be columnar cells. Previously I have told columnar cells will be there in the middle ear cleft, and goblet cells will secrete mucus. That is why it is mucoid in nature. When it is suppurative infection, when bacterial infection is there with the mucoid discharge, it will be mucopurulent discharge. And if it is long standing and untreated disease, mucopurulent can become purulent discharge. Next will be about nature of discharge, whether it is intermittent or continuous. Intermittent will be there in safe type, which is also called mucosal type. There will be the irritated columnar epithelium or irritated mucosa of the middle ear can be suppressed with the medications. It can be suppressed with the medications, and it will be aggravated with upper respiratory tract infection. But in unsafe type, it will be continuous. It will not be relieved with medication, but it can be aggravated with upper respiratory tract infection, but it will not be relieved with medication. Next thing we will ask about odor of the discharge, or odor or foul smelling, whether it is foul smelling. If it is foul smelling, it is unsafe type, because this foul smelling is because of the erosion of the bone, or it can be because of the bacterial infection also, anaerobic bacterial infection. If it is anaerobic type, it will be foul smelling. But in safe type, it will not be foul smelling because there will be no erosion, but it can be foul smelling when there is anaerobic infection. Lastly, we will ask about the blood tinged discharge, whether it is blood tinged or not. Whether it is blood tinged or not, we will ask about it. If it is blood tinged or blood, if the discharge is mixed with blood, it is unsafe type. Why? Again, I will tell it. Why there will be blood tinged? Because of the erosion of the bone. Inside the bone, there will be small capillaries. These capillaries will be also eroded with the disease. Because of that, bloody discharge will be there. Of the patient, like hearing loss, or it is also known as decreased hearing. Patient can say decreased hearing or impaired hearing or deafness. So when patient complains with hearing loss, we have to ask about side, which side it is, left or right. Left or right. We have to ask about. Next, we have to ask about the duration, for how long the problem is there with the patient. And then we have to ask about the onset. When was it? When was the onset? Whether it is uh, since birth. Since birth will be congenital causes, congenital, or it's later stage of life that is acquired. That could be because of trauma or infection. Next, you have to next you have to ask about whether the patient is hearing better in noisy environment. We call it hearing better in noisy or crowdy environment. The term is also called paracusis willisii. Paracusis willisii. This is mostly seen in autosclerosis. Okay. Next, you have to ask about autophony. Autophony means self. So autophony means you are speaking and you are hearing yourself. That autophony. It occurs in mostly in when there is fluid in the middle ear, serous otitis media, or due to patulous eustachian tube. Patulous eustachian tube means when normally eustachian tube should be closed, and when we yawn or when we swallow, that opens. But in patulous eustachian tube, mostly it will be open by itself without doing anything, without yawning or without swallowing. Next, you have to ask about the fluctuation of the hearing, whether the hearing loss is fluctuating. It can occur in mostly this is we call it fullness and fluctuating of hearing loss in Meniere's disease. It can occur in other causes also, but mostly we say it in Meniere's disease, also in otitis media with effusion, SOM, serous otitis media. And we have to ask about the hearing loss, whether it is progressive or not. Whether we have to ask about the occupation also. Occupation, like why occupation? Because noise induced hearing loss, it occurs in, there will be, if we do PTA, there will be dip in 4000 hertz. 4000 hertz, if you see dip there in 4000 hertz, it is mostly because of the noise induced hearing loss. You have to ask occupation. Why? Because the if the person or patient is working in a noisy environment, like where blast occurs frequently, or where uh, choppers chopper fan sounds. Next we will come to earache. Earache. So here again, like usual, you have to ask about the side, whether it is right side or left side, or it is bilateral, the duration, onset, suddenly it started or it started gradually, and you have to ask about the type of the pain, severity. Like in in general surgery or general medicine, you must have been taught about asking about pain. Whenever a patient complains of pain, what you have to ask, what things you have to ask is, first in this one, in particularly this one, what you have to ask is side, with which side it is, and duration or onset. This is common, you have to ask in every history. Particularly in any pain, what you have to ask is star square. What does star square means? Double S, two S's. First S is site, next is severity, next T, one T, two T. T will be type of pain, or and next is timing of pain, when it pains. Next A will be associated symptoms and aggravating factors. Aggravating factors. Next last will be R. Two R's are there. One will be R. One R is whether the pain is radiating pain or not. And next R will be referred pain. So any pain you ask, this star square you have to remember. Two S's are there, site and severity. Two T's are there, type and timing. Two A's are there, associated factors or associated symptoms associated with, or it is any aggravating factors for pain. And next will be double R. One R is radiate pain, whether the pain radiates to some any part or not, or it is referred pain if it is referring or not. This tinnitus. Tinnitus, what you have to ask is, again you have to ask about the site, duration, whether it is onset, how it is onset. These three things you have to ask everywhere. Then you'll ask about whether it is intermittent or continuous, and type of tinnitus, whether it is any low pitched or high pitched roaring sound or hissing sound or bell sound, whether the sleep is disturbed or not, whether use of any ototoxic drugs, like history of drug. Mostly you should remember quinine, which is used in malaria in aminoglycosides. Next, coming to the last symptom, we will be seeing vertigo. These are all related to CSOM. Vertigo, what you will ask again, the duration, and vertigo. If the patient is having vertigo, which side he tends to fall, like side, again the side, duration, onset you have to ask. Suddenly it occurs, or so most importantly, what you have to ask in vertigo. Vertigo usually when any ear vertigo is if it is caused due to inner ear, it will be mostly of spinning type of vertigo, spinning sensation of self or surrounding. That will be because of the semicircular canals. So you have to ask whether the patient is having spinning sensation of self or surroundings. And you have to ask about the associated factors like hearing loss, whether it is associated with otorrhea, ear discharge, whether it is accompanied with nausea or vomiting, whether the patient is having associated symptoms like decreased hearing, discharge. That's all. This is the history. That's all for history taking.